Yeah. Perhaps just briefly talk about our project approach. You know, traditionally we've focused on investments, which we looked at inputs and trying to provide all the inputs. But in the last 10 years, we have started to shift towards results-based financing, in which we finance the results, even if it's intermediate outcomes and maybe not all the way out to outcomes per se. We have gained considerable experience over the last 10 years in this area through our results-based financing platform, and we're beginning to expand on that. Now, about 45 countries are now engaged with us in this area, and what is remarkable is this is different from pay-for-performance, which is about paying individuals or groups for performance, its payment system. It's really taking project-wide results-based financing so that it can take a much broader look at how we reimburse, how we finance. And so it gives us a lot of scope for innovations and see how it incentivizes whether groups or systems to behave in a different way. Another aspect of the results-based financing, perhaps more important than the payment itself, is to have an independent audit or technical audit system. And by having the independent audit or verification institution in place, that changes enormously the governance and the incentives. We found that that is in many ways more important, but also it's the most difficult part because many governments, I won't name them, are very reluctant to move in this direction. So we've done them in small scale, but scaling them up to a nationwide approach will require a substantial change and transformation in the whole institution structure. So this is why it is a litmus test in a way where the governments are really willing to be accountable.
Hello, can you hear me?
Oh, great. Good. Yes, yes, Khama, great. We can hear you now. So we'll put up the PowerPoint.
Thank you.
And just tell us when to change the PowerPoint if you can't see it. We have the title page now, Khama. Go ahead, please.
Thank you very much. Thank you very much. Apologies for the technical glitch. We were on throughout, but something happened. For information, the temperature outside here is 40 degrees Celsius. So if you people have any problem, know that you want to melt, just send it over. I want to talk a little bit about lessons from 7 African countries as part of the Health in Africa initiative, which was started 5 years ago by the World Bank Group in response to the Red Book called The Business of Health in Africa. That concluded after looking at what was happening in Africa over the last 20 years, that the continent was unlikely to meet the MDGs if it did not fully embrace the non-state actors, the private sector, and got the potential, big potential investment that exists within that particular subsector. Slide number 2, please. That slide shows you the mission of the Health in Africa initiative, which was to catalyze sustained improvements in access, looking at quality of both goods and services, and above all, create an enabling environment for sustainable private sector participation. In working in this area in the 10 countries that we've been involved in, one of the things that came out immediately was that there was very little data on non-state actors, despite the fact that in all countries, out-of-pocket expenditure far exceeds government and donor expenditure. That the non-state actors, private sector, employs most of the skilled workforce, and that the bulk of the people going for care do go, first of all, to non-state providers before eventually ending up everywhere. So in looking at these two, we realized immediately that there was no disaggregation of data by gender in terms of who these people who work in this sector are and what they do. We decided, therefore, in slide number 3, which is the next one, to look at what was happening in 7 countries, both Francophone and Anglophone, both post-conflict like South Sudan and more stable like in Kenya. And we looked at the literature in terms of the human workforce, particularly women and looking at them in what they do. We collected data, we analyzed that data, and then we held stakeholder validation workshops in all these countries to check with the people who are really doing the work whether those findings were credible, but most important, to come up with national actions on what to do. And if you show slide number 4, it basically summarizes to you some of the things that we rarely look at but are important in this kind of work. You will see that when it comes to women, their reasons for joining the health sector and in private sector are pretty well defined. This is quite different from the male counterpart. And if we had time, I would give you the data from the male side. But for women, it is that they want to get better income, they still want to develop professional skills, and they care about the quality of services. Issues about leadership and other things that are very common in this kind of question to men did not arise. But most important, we did find that the bulk of the people who are in this non-state actor sector, the private sector, who are employed there are mainly women. But they are very thin at the top. They are not the managers, they're the owners of the business. They are usually employed in the lower areas. It's only in the midwifery area that we found that women were the majority. But in the rest of it, yes, the numbers were big, but they were there mainly as employees. And the summary of the barriers to this female participation and leadership in this area could be classified in all the 7 countries in 4 areas. The socio-cultural, the very deeply embedded institutional reasons, the skills that are required to survive in this sector, and financial reasons, access to finance in particular. And the report that we'll be bringing out goes into great depth to look at some of these issues. And in the earlier presentations, I did hear several of the speakers articulating some of these things, but in these 7 countries we have for the first time put together what is needed and where the gaps are. Now, if we look at those areas, then comes the next question, is that are there things that we can do something about? In slide number 6, I'm giving you an example of some of the intervention areas that have been identified and that we are working on in several countries. First of all, policy and legislative reforms are needed. Yes, for us to reach universal health coverage, this is going to be particularly important. Unfortunately, rarely do we look at policy and legislative reforms in this sector.
So, next slide,
through the gender lens.
Yeah, yes.
And when we look at some of the changes that have taken place in these countries in recent years, we find that there are some of them that are actually negatively impacting on the participation of female in this particular subsector. So this is particularly important in gender lensing. Unfortunately, it's not something that is done often in this sector, but one that we must start taking seriously if we are to get the other half of humanity on board. The second area was the area of formalization. We did find that by and large, most female-owned enterprises tend to be informal, even in the area where they dominate, such as midwifery. Because we did find in Ghana, for example, in Uganda, and in Kenya, that we have a lot of midwives who are in practice, but have not renewed their licenses for more than 5 or 10 years. They are working out there, they're probably semi-retired and so on, and they don't see the need to do this. So they're doing their thing. They're not building this business into anything that is more formidable or growth. And this is probably enhanced by the fact that most programs that have looked at midwifery, especially private midwifery, have tended to focus on the retired midwives, not the young ones who are coming out of college. And this has advantages, but obviously in terms of entrepreneurship and growth, it has a major negative effect. So that private midwifery is seen as something that is done by people who have retired from government, but not people who are leaving college and want to put their energy into growing the business and making this work for their country. So formalization is important. Why is this important? Because as health insurance, especially social health insurance, expands, and in Kenya and Ghana we've seen rapid expansion in this area, only formal businesses can be accredited under insurance. So that means that a lot of potential businesses in midwifery and others are missing out simply because of lack of formalization. The third area is the skills, and here the skill sets that are needed to run a business in the private sector in health are quite different from those that are needed in working in the public sector. And the study finds very, very many areas where the skill sets that midwives need are not there. And the few attempts that have been made, mainly by NGOs and some of the donor supported programs, have not looked at the gender friendliness of the kind of training modules that are developing people into the businesses that they want. So we are now working with WAHO. In fact, that is why I'm in Niger now, because I'm addressing the West African health ministers this week on this very issue, to try and see how we can start focusing on the workforce that can be obtained from this gender perspective in terms of training and the skills that are needed for us to be able to move forward. Remember that we are talking in a sector, the health sector, where basic training never prepares you to go and work on your own, either as a doctor or as a nurse. Usually trains you to be employed. In countries where the margin for employment and increase in employment and opportunities are getting less and less for the numbers that are there. Similarly, the ICT. We did find, too, that the female entrepreneur, that nurse midwife who's out there, particularly retired ones, are pretty poor in ICT. Again, we are talking about a continent that is fast moving into ICT. You take for Kenya, for example, where a good proportion of the client payments are coming in through M-Pesa and other electronic ways of money transfer. If the female part of our workforce is not there, then they're missing out. And then, of course, there's the financial area. Access to finance remains a big, big one beyond what is generally known. And when we look at the portfolios that exist in terms of commercial bank lending, for the private health sector, it has been less than 1%. It has grown to more than 5% in all the countries where we're working in. But when you look at this portfolio, very, very few are lending to women in the health business. Again, tied to some of the socio-cultural issues, the issues of collaterals. So one has to start coming up with collaterals that don't depend on male. And in the study, we find that most successful women entrepreneurs in the health business immediately thank either their husbands or their fathers for making them get that start that they needed. In other words, those are the people who could provide title deeds. Those are the people who could go to the bank and be trusted with the money. Missing, too, has been the area of group practice. Group practice amongst females is pretty rare. In an area where you'd think that this would be useful because they want to take time off for maternity, they want to take time off for the family. But if they are individual practices, this does suffer. And we see this as an important area from this study where more work ought to be done. Somebody didn't mention the PPPs and the OBAs, the kind of financing that is there. The study finds clearly that some of the result-based financing initiatives, especially in the maternity and family planning area, have been particularly useful, disproportionately useful for women health workers because of their ownership of maternity homes and so on. That is when they are appropriately formalized. So this becomes a big, big area of potential growth. And as we go into the global financing facility that I'm sure will be mentioned later, this is an area that we ought to look at if we're starting to look at the gender and the workforce and the midwife in this particular area. Similarly, in health insurance, what we've seen is that helping the formalization in Ghana and in Kenya has increased the number of health businesses that can be accredited to social health insurance in different countries, because they are now trained and they're eligible for this kind of accreditation. Again, things that can be done and can be done quickly and can make a difference. The toughest area is the sociocultural area, where gender and I emphasize community empowerment is needed. Because this is a situation where the study finds that the discrimination against the woman being in the health profession and being independently an entrepreneur are enormous. And this starts right from childhood into high school, where getting into the health business and the health faculties becomes a discouragement by many people. And when you come out, you are expected to behave in a certain way. Go to work and come back at 4 and not be in your business where you need to be there longer. And this has kind of modeled the kind of specialties and subspecialties that female health workers find themselves in. So we found that you very, very rarely find them go into the more time-consuming things such as cardiology and so on, because they would have to be away from the family at odd hours. They would rather go into dermatology and things like those. And these ones do limit, therefore, the range of expertise that women can bring into the field and things that must be addressed. But most important in the study is a lack of mentorship, lack of role models. Every training institution, be it nursing, laboratory, or for doctors, the role models that are brought to talk to students are never women. And if they're women, they're never women who are entrepreneurs in the health sector. So where do you get the young woman who is either a doctor and a midwife starting to think early that, yes, I can go into this and build my own business that can grow into helping the community rather than just being a follower everywhere else. And during the validation workshops, we did meet groups of women, successful women in business, who are very, very ready and willing to play this role. And not only that, but during a vacation, bring young women who are still students into their clinics, into their practices, so that they start learning the ropes on how to do this. But most important, building them into partners so that later on group practice does work. These are important things, and the time will not allow me to go into details on this, but several things that come out of this study. Number one, we are not going to do universal health care if we do not get the private enterprise and entrepreneurship in Africa moving. Two, that entrepreneurship is also in our women, but we need to help them overcome the sociocultural, the institutional, the skill area, and the financial barriers that make it impossible for them to move forward. But most important, that a lot of these things can be done within the framework of changes that must take place if we are to enter into the area of universal health coverage. Through the Health in Africa initiative, we have shown that these things can be done, that they can be done quickly, and they can be done sustainably. And my hope is that through discussions like the one that you invited me to, we can form the kind of partnership that starts the business unusual. And the business unusual in this area is how to get into entrepreneurship in health and how to make sure that women are mainstreamed into it. I'll stop there.
Okay. Thank you very much, Khama. I cannot top that. So that's an excellent conclusion, and I'm aware that the time is up. I'm sorry we won't have time for Q&A, but I'm sure there will be opportunities later on. So thank you, Khama. Thank you, Somil, for connecting with us. So
Thank you. Thank you very much. And again, let's thank our panelists. Yeah. And it's very exciting to hear how the World Bank has transformed to be as relevant as some of the programs that you're describing. So we now come to a break. We can have some conversations over coffee, and we will resume at 11:15 on the impact and insight. And then I promise I will we will have some time for conversation and discussion at the end. Perhaps a little bit at the end of this panel, but then later on too. So we'll see you in 15 minutes.